start the treatment before the growth spurt so the differential horizontal growth can fix somewhat of class 2. No orthodontist or dentist can grow a mandible. Uncoupling the occlusion is good. Can you give me a common appliance which uncouples the occlusion? Aligner. In other words, if you have a growing class 3 patient before the growth spurt, would you like to do aligners for that patient? Why? Because you don't want to uncouple the occlusion. Is it clear? So you need to write it down. Do not do aligners in phase 1 in a class 3 patient because that can uncouple the occlusion and express the mandibular growth more than what you want it to. Growing class 3 patient, aligners should not be used. But in a class 2 patient, uncoupling the occlusion is going to help you. So for a growing class 2 patient, aligner is a good therapy because it's still going to give you class 2 elastics, it's going to align your teeth, uncouple, express horizontal growth, everything. So in a class 2 growing patients, aligners are very, very suitable appliance since it fits every requirement. Okay? In Dr. Megann's growth study, that's where whatever I wrote there was called the estimated growth system, and now you have the individualized growth system. In the individualized growth system, Dr. Megann did the following. He took two factors. One is called the Megann angle. Megann angle is the angle formed between the maxillary length and the mandibular length. What is the maxillary length? It's a line connecting condylion to a point. This green line is called maxillary length. Line connecting condylion to a point. Then you have another line that connects condylion to naphtheon. That's your mandibular length. The angle formed between these two lines gives you the Megann angle. In other words, it gives you the skeletal vertical of the patient. Is the patient skeletally open, average, or closed? Can you give me another example of what gives you the skeletal vertical? Sorry? MMPA is this. FMA, Frankfurt Mandibular Plane Angle. And I'll be talking to you about this on day 4 of this seminar. Okay? There's another factor called width. What is width? Width gives you the patient's skeletal AP. This one gives you the patient's skeletal vertical. Skeletal AP is calculated by width. How is width calculated? You have something called an occlusal plane. Okay? If you draw a perpendicular line from the A point to the occlusal plane and the B point to the occlusal plane, these lines should meet. If these lines meet, it's class 1. If the B point is ahead of A point, it's class 3. If A point is ahead of B point, it's class 2. So it gives you the patient's skeletal malocclusion. This is another factor that he involved. Based on the widths and the Megann angle, in the Burlington Growth Center, he traced 686 growing patients were studied. 2,000 cephalometric X-rays were traced by hand and put together to predict growth. And he got an individualized growth predictor, which is now incorporated into your MOS software. The moment you call this as a growing patient, it already has your widths, it already has your MMPA, so it marries these two values and gives you a growth prediction and moves the mandible forward by that much of amount to show that much of differential horizontal growth is going to happen in this case. Okay? That's how it is. The moment you call the patient growing male patient, and I was telling you to choose a stage Stage 2, stage 3, stage 4. Do you know what the stage are right now, right? Look at the CBM or look at the hand wrist. When you add that, it will move the mandible forward by that many millimeters. Okay? And that's the growth curve. We spoke about that already. And we spoke about this. One curve, two curves, three curves, square and a tall rectangle. And pisiform, sesamoid, capping and nuding. Spoke about all this in detail already. Stage 3 is called the growth peak. In your simulation, if you want to use growth, you can first work up on the entire case as a non-growing patient and see what your growth simulation is and save it. Then start a new project and add growth, and then you can compare with growth and without growth how much is your change in treatment decision. Okay, you can save it as a different project. Let's look at another case. This case is by Dr. Rubna Masoom from Australia, mentored by Dr. Collins. Alright? All of these examples, this is one of Rubna's first bracket case. Is this a good case to start with? What does this profile tell you? First thing you look at is a profile. I feel like her lips are way behind on her face. She will look better if I can bring her lips forward, right? This also shows that the canine is ectopic. The upper midline is shifted towards the patient's left. On the smile, I don't see her incisor inclination at all. On the facial picture, I don't see any mandibular deviation. Do you think she's meso, brachy or dolicho? I feel like she's meso. Okay? What else do you want to see in the case? Upper midline is shifted towards the patient's left. Intraorally, what do you think about the tissue? Is tissue an issue? You don't know, because the cheek retractors that are being used are not good enough to retract the lower lip completely away. So if you send a picture like this, even we cannot guess. It looks like 3-1 has gingival recession. But I can't see this so clearly because the lip is covering that incisor, right? But let's just say that it's thin because it looks like it is thin. Do you see something peculiar here on this side? I see that the patient has a posterior crossbite on both sides. Okay? What do you think is a curve of speed? It's deep, right? It's coming in here and it's going all the way up, so deep curve of speed. How much is the crowding? I see 1, 2, 3, 4 millimeters of crowding in the lower. On the upper one, and this canine is completely blocked out. So 8 millimeters of crowding in the upper, 4 millimeters of crowding in the lower, and 8 plus you have something here as well. So 9 to 10 millimeters of crowding in the upper. A lot of crowding. How's the patient's dental vertical looking? Is it average bite, open bite, or deep bite? I think it's average, right? What do you think is going to happen to this if I align the case and treat this patient non-extraction? The bite will open. So bite opening is one of the reasons why you want to consider this patient as extraction. But will you extract for that face? No. So what do? See the options you have for extraction and non-extraction. In my mind, profile says non-extraction. Lower anterior tissue says extraction. Bite opening says extraction. So you have all of these options. This is why you want to work up the entire case to come up with a treatment decision. What about class 2? Half class 2 here, about 2 millimeters class 2 on this side. So she also has class 2 to correct, which can further open up the bite. Okay? So facial profile, I think she's somewhere in the green zone. Oh, facial profile is red zone. Lips are intruded. Facial type, she's in the green zone. Upper midline to the left. Resting lip to incise and edge is green zone. Is it okay to advance the teeth? No, because the lower tissues are thin. Is it okay to expand? You have to go back and look at the tissues here. Is it okay to expand? Yes. And you have to anyway expand because the patient has posterior crossbite. Whenever you treat a patient with orthodontics, this is the chronology of treatment. TVAP. T stands for transverse, V is for vertical, A is for anteroposterior. You cannot fix the AP unless you fix your V and your T. Okay, so first thing you need to do for this patient is you have to expand the upper. And what's her age? Her age is 11 years old. Can you do a bonded rapid palatal expansion for a patient who's 11 years old? Yes. Okay. The upper limit is 15 years. 15 years is when you expect a growth to be completed in the bird. So till 15, if she was my patient, I would have done a bonded RPE immediately. If I do bonded RPE, it will give me skeletal expansion by opening up the mid-palatal suture of the upper jaw, which is considered to be much more stable than anything else, than expanding with aligners or expanded arch wires. All that is the best expansion would be opening up the mid-palatal suture. Let's press on. So anterior overjet, insufficient. Arch length, crowding. Vertical, open. So she has a lot of red flags. So if you have a case like that, work with a mentor. Don't do this by yourself because I don't want you to get stuck. Okay, so I saw somebody's case, like your case, doc, the first case you showed me. You need to work with somebody for that case because the premolar was missing, molars were rotated. I asked you to refer it out right now. If you're doing it yourself, you're going to work with someone who can keep mentoring you at every step. If you do that, there's a lot it can teach you as you start. Okay? So there are two ways of learning. POS recommends that we start with easy cases, and as you get better, take difficult cases. But when I was a student, the first few cases I took up were all difficult cases. My thinking was, what if I just take a most difficult case, take somebody's help to fix it. As the problem keeps occurring, somebody's holding my hand, I learn a lot more faster. If you learn swimming, would you learn swimming on a shallow pool or a deep pool? You want to swim? You want to swim? Have you seen people swimming? When they teach you swimming, on the first day, they throw you on a deep pool. It was automatic for you. You have to survive. So you will start moving your hands and legs. That's a faster way to learn swimming than me putting you in a 2 feet pool and show you, okay, make this baby, make all of it. You can still learn that way, but it takes a longer time. If I put you in a 10 feet pool and you have to survive, you have to breathe, you will move your hands and legs and you will learn faster. So if you take a difficult case and you have someone to guide you, but when they throw you in difficult pool, deep pool, they have a guy there to hold you. For some reason, if you can't come up, he'll bring you up. Okay, so you need someone to hold your hand. Okay, what do you think about the eights? Do you think we need to extract eights early or no? Upper eights, completely not needed, somewhere up there. Lower eights, if you have a person with deep curve of speed and you want to upright the 7, the lower eights need to go out. But it's difficult to sell that plan. How are you going to talk to the mother about extracting the 7, 8s with the surgery on an 11-year-old girl? It's a difficult sell. Okay? So if you can't sell that, then maybe you'll accept some amount of tipping in the 7s. Okay? It's perfectly fine. On the cephalometric X-ray, I can see that lower jaw is way behind. Isn't it? Do you think it's a skeletal problem or a dental problem? It's a skeletal problem. She has class 2 coming from her retruded mandible. On the frontal ceph, I don't see any functional shift. Looks like right side is much more taller than the left side. So maybe there's some amount of skeletal asymmetry. Then you form the occlusal plane, keep going on the same way. So the width shows you that width is 0.45. Anything between -1 and 1 in width is considered class 1. But I told you there's a skeletal problem. How can you have a skeletal problem in a patient who has class 1? Width takes the relationship of the maxilla to the mandible. It does not take the relationship of the bone to the skull. The maxilla and mandible are well related to on top of each other. But the mandible is very, very retruded compared to the skull of the patient. Can you see that it's way behind? So you cannot extract in this case because the mandible is retruded. So patient has dental class 2 with retruded maxilla and mandible and skeletal class 1. So the maxilla and mandible are related well, but both these bones are too much behind compared to the face of the patient. That's what the cephalometric tells you. Okay? If you see the shape, you can see the arch wire chosen here fits very well on the lower, but is so expanded on the upper because the upper is a constricted arch. The blue line shows you there is no asymmetry at all. Class 2 is minimal, so you should get class 2 simulations that are class 2 elastics, expansion and IPR. You will not get a distalization since the amount of class 2 is less than 3 millimeters. Okay? And that's your 2.1. Do you like this picture? I think it's good. Just see the amount of expansion on this side. Purple is where it was in the beginning. Brown is where it's going to get after you expand. It's showing that the teeth are expanding a lot. Is this really going to happen clinically? We have to check. Okay. Last two elastics show you that the lower incisors are outside the bone. So you have to do expansion. You're anyway planning to do expansion. But they chose this as a treatment plan with brackets. And look at this, what you got. On the bracket output, for the upper incisors, you got a LI bracket, as you'd expect in a class 2 case. Lower, you got SLA. SLA means the lower incisor is going to be very, very upright. It will not allow the incisors to procline at all. Okay, nice and upright, because you're going to use class 2 elastics. That's the plan. Everything to me looks good. I'm only not convinced with one thing, is they are not expanding the upper. Okay. For the profile, if I was treating her, I would do 2.1 also. Before I do 2.1, I would like to expand, hold the expansion, and then do 2.1. Okay? So if I don't fix the transfer, I start aligning the teeth, what do I expect to see clinically? I expect a lot of bite opening, since the back teeth are not having a proper cusp to fossa relationship. As they align, it goes cusp to cusp, the bite will keep opening. And she has a lot of crowding as well. So we'll see what happened. So just like we discussed, the skeletal class 1, and she's open, the FMA is 29. This was planned on Smile Stream. This is how we do expanded arch wires, and that's the VTO. Bracket top, plan design. When you click on treatment plan, it gives you step-by-step treatment plan. Okay? Additional instructions from the mentor. Size the bands of upper and lower sixes and enter the band size on Smile Stream. What band will you have for the lower sixes here? If you're expecting to use a lot of class 2 elastics, we would use a C2E band. Right? Then as you align upper 6 to 6, lower 7 to 7, because patient has deep curve speed. So you align from lower 7 to 7. Initially, do not bond 2.23 because 2.3 is completely outside the arch. You can delay bonding to 2.3. Pack open coil springs between 2.2 and 2.4 to create the space for 2.3 and then align 2.3. exactly how it looks. Bond and band, you have 2, 3 that's skipping, then you have open coils to open up space. Stainless steel open coils are used to open up space by moving multiple teeth. Are you moving multiple teeth here? Yeah. All these lower and upper anteriors and posteriors are going to be applying pressure. When you want to move 1 or 2 teeth, then you need low force. That's when you would use Nitai open coils. When you want to move multiple teeth, you have to use stainless steel open coils. Okay? And let's go on. This is a very common case. Okay, just follow the case along because you will soon have a case of ectopic canine. It's not a very uncommon thing. What do you see here? Do you see bite opening? Yeah, it's a lot of bite opening because as you open space for the canine, what is going to happen to the upper incisors? The upper incisors are going to fall forward and the bite opening is going to worsen. And very soon they go to O16 nitai. The lower, all the rotations are corrected. The upper looks good, but this tooth number 22. What do you think is the problem with tooth number 22? Not enough? Yes. You can see the roots of 22 is far behind all the other teeth. So what bracket does this one need? LA. Okay? So the roots can go labial. Excellent. Can you see the small bracket here? That bracket is called a PE bracket. PE stands for partially erupted tooth. When you have your sevens that have not fully erupted on a growing patient, but you're starting the case early and the patient has a deep curve of speed. Whenever you have a deep curve of speed, you have to involve the sevens. Why? Because the curve of speed is leveled by the extrusion of bicuspids. So if you go all the way back to the 7, only then the bicuspids can nicely extrude and level the curve of speed. So if you don't have 7s that have erupted, you can bond a PE bracket on that and then extend it all the way behind in the alignment stage. Okay? What do you see here? Elastics. Why are they giving elastics? Because the bite is opening. If you see something like this in your clinic, when you started the case which did not have an open bite and open bite starts showing up, it is most likely because the transverse has not been fixed. As your teeth align, bite will open. If you don't do anything at this stage, you will develop tongue thrust. So this is a situation to panic. Do you panic in your treatment? In ortho, it's very rare to panic, right? If you move the tooth from here to here, you can always move it back from there to here. So it's okay. But if you want to panic, this is the time to panic. If you see bite opening, you have to shut the garage door immediately. That's what we use. When you see the bite opening, shut it right there. How do you shut it? This is the picture. You have to start them on elastics. Now, what elastic is this? This is called a triangular elastic. Okay? That is the 3x16, 4.5 ounce, the last one on the list. That's called the gorilla elastics. These are short elastics which can extrude the teeth and keep the bite closed. So you have triangular elastics on both sides. Okay? That's a mandatory thing. In the anterior, you have something like called box elastics. Box elastics are same gorilla elastics again, but they go from lateral to lateral, 1-2 to 2-2 to 3-2 to 4-2. All of these together to shut the bite. Do you think the patient will wear the box elastic? The answer is no. So what do? You have triangular elastics, we own 24 hours. Box elastics, bedtime. Because when they wear box elastics, why will they not wear a box elastic? Because they can't speak. If I wear box elastics and talk to you, this is how I'm going to talk to you. I can't open my mouth. So they can't wear it. But at night, hopefully they don't speak at night, so let them wear it at night. You need to know this because this is going to happen to you. Bite opening during treatment is a very, very common problem. Most doctors don't address it, and by the time you start addressing it, the patient already has tongue thrust. You cannot swallow with your mouth open. Try. You swallow with your mouth open. That's what the patient feels. The bite is open. They can't swallow. So for them to get a seal, they have to put the tongue into the open bite so that they can swallow. And how many times will you swallow in a day? So you will start developing a tongue thrust. So you have to shut this immediately. Okay, that's what is being done. How can you apply elastics on a lateral incisor bracket? Because it doesn't have a hook. So you use something called Kobe hooks. Kobe hooks are a short form of Kobayashi hooks. They are something like a steel ligature tie with a hook. They are made up of a thicker gauge wire, like an 014, because it has to tolerate the force of elastic. Kobe hooks are applied on the lateral incisor of all sides, and the elastic goes around the Kobe. Okay? Please take a picture of the slide, because when you have open bite, this is exactly what I want you to do. And you will not remember it. Put it on your notes saying management of intra-treatment open bite. If it develops during your treatment, this is what you will do. Because you will go through a lot of back and forth emails, questions. What should I do? And then you use elastics. From where to where? Triangular in the side and box elastics in the front. Triangular in the side from where to where? Upper canine, lower premolar. Anterior, I don't have an elastic to hook on. What should I do? Kobayashi hooks. So this will take 1 week. If you write and we write, you write, we write. But if you have a picture speaks 1,000 words. Okay? Can you see lower tissue recession? This is a red flag. Let's go on. By the way, what's the classification now? Is it class 1 or is it class 2? It's hard to guess here when it's open. What about this side? Class 1, right? How is it class 1? I haven't even done any elastics yet. Huh? Curve of spleen? Okay. Anything else you can think of? Curve of spleen level is when your molars are class 1 and the canines are class 2. This one, the molar also was class 2, isn't it, from the start? But now it's class 1. How? Thank you. You're paying attention, man. You didn't sleep after lunch. Well done. I was going to give you a hint. It starts with G. Yes. Okay. Growing patients. This is what you'll expect. And you'll be surprised to see, wait, how is it class 1? It's class 2 last time. How come it's class 1? Because of differential horizontal growth. How can you be so sure? For you to be so sure that growth is doing it, you have to take another cephalometric X-ray. Trace it. Then you overlay it. Overlay A point of your start X-ray and A point of your progress X-ray. A point is keeping the maxilla on top of each other. And see where the mandible is. If there's no growth, then the mandible also will be on top of each other. If there's growth, the progress ceph will show you the mandible is ahead of the maxilla. Okay? That's how you decide and understand. The doctor told Dr. Collins that patient was an 014, today I replaced with 016 in the lower jaw, all of this. She has bite opening, I put box elastics and gorilla. Great job with the elastic. She has tongue thrust for sure. Now tongue thrust is another villain. If you have a person with tongue thrust at start, it becomes a very, very challenging case because between you and the tongue is a very strong muscle and they will win. Okay? Patient comes back, bite bite has improved a lot since the last appointment. That means the patient has been wearing the elastics well. Okay? So Dr. Collins says, congratulations, this case has come a long way. And since all the rotations are now corrected, you can move to 18 by 25 heat activated night eye wire. Okay? And let's go on. How is the bite looking on the right side? Great, right? It looks excellent. Class 1 occlusion. On the left side, still some amount of bite opening is there. Maybe she still has tongue thrust. If you have tongue thrust, how do you control tongue thrust? You need to bond something called lingual cleats. Lingual cleats, before you bond them, you have to open them. Bond it on the lingual surface of the upper anteriors. Tell the patient not to touch that with their tongue. That's a reminder. Every time they touch with their tongue, it will poke them. So tell them whenever you feel that's happening, stop doing it. So this is how you train them to get out of tongue thrust. This is how a lingual cleat looks. The problem on the lateral incisor is, although you have a lingual cleat, it is not open. There's no point having something that's not open. On 2, 3, you can see that it's open. So when you bond this, when will you open this? Before bonding or after bonding? Before. If you open after bonding, you will hear a noise. Yeah. And a small vibration will pass through your entire body. So you now know that you have to do that again. You just have to experience this, man. You'll love it. Oh, God. Just have to do it again. Okay? So please open it before. I shouldn't have told you. I should just let you feel it once. So open the cleats before you bond and tell the patient not to touch it. Okay? How are the roots looking? When you have 2 months of 18 by 25 night eye, you must take an OPG to check if the roots are parallel. Are the roots parallel in this case? If yes, no problem. If not, which is a tooth that catches your eye? I think tooth number 3-2 has got a lot of distal root tip. So yeah, 3-1. I think everything else looks reasonably okay. That's off. This is off because the bracket is going distally, the roots are going more mesially. So you need to look at the long axis of the bracket and the long axis of the tooth. The long axis of the tooth is your root canal. The long axis of the bracket is the radiolucent line present in between the tie veins. Both these lines have got to be parallel. Okay, that's how you look at it. If you see in this case, it's going more distally and the root canal is going more mesially. So this needs to be fixed. Let's go on. How is this case looking now? It's just been 10 months since you're treating this case, 18 by 25. I think the occlusion is so good. If I was a treating doctor, probably I wouldn't have gone to 19 by 25. Because this is like a one-wire technique, isn't it? The one-wire technique we spoke in the morning today, where you correct the rotations on a round wire, do 18 by 25 and fix it on 18 by 25. Okay. So 3-1 may be overcorrected. And you see, if you see the amount of tooth that's visible on top of the brackets on the lower incisor, it will tell you volumes of how you need to fix this. You can see that tooth number 3-1 is too much overcorrected. 4-1 also is off, so this needs to be fixed again. Okay? And the canine lingual cleat is missing. Would you be worried? No? You don't know, you open that cleat up, right? The patient swallowed it. Would you be worried? So when you have missing lingual cleat, you have to ask them, did you feel something has come out? That's the problem with lingual cleats, and that's why I don't use them as much. If you open that up and something gets debonded, if it comes out and you throw it, it's okay. If you swallow it, now I'm worried because now it can go get stuck somewhere in the GI, right? So that's a problem. Patient instructed to wear class 2 elastics. That's the keyhole. This is the class 2. How much is the class 2? 2 millimeters of class 2 on the side, 1 millimeter class 2 on the side. Continue. Do you think the amount of overjet is good for the class 2 connection? It's perfect. If it's not good, then the class 2 elastics will not work. Okay, so you got to do something. Now this you see here is called a Warren spring. The Warren spring is used to add torque on a single tooth. If I take the Warren spring and put it on this tooth here, it will push the roots lingually. That's what this tooth needs. Okay, so you have to use a Warren spring. This is a periodontal probe that is used to measure the amount of overjet, just to make sure the amount of overjet is more than the amount of class 2. Okay, otherwise the case is looking very nice. After you achieve class 1, you have to move to a finishing stage called 018 stainless steel. This is the wire that responds very well to elastics, and this is the wire on which you can make some finishing bangs. Okay, and you see some root resorption. This is the X-ray taken a few months ago versus the X-ray taken today. You can see that the root is shortening. What do you do when you see root resorption? First thing you do is you got to inform the patient, because it's not you. It's never your mistake. Okay, it can happen to anybody. There's nobody who can say I've done ortho without root resorption. That means they haven't done enough work. It can happen to anybody. Inform the patient and go ahead. And Dr. Collins says everything is looking good in terms of alignment. She has very thin tissues, but I still feel non-extraction was a call because the profile could not tolerate extraction. Please refer her to a periodontist for a free gingival graft. Okay? All of this should have been spoken to her before. And again, you see some short elastics to upright. How did it become bad? It already was good before, right? It's becoming bad because when you expand the teeth with an arch wire. How did they get the expansion here? They use an arch wire. So arch wire will give you bodily movement or tipping movement. Tipping. So when you remove, everything is going to be having somewhat of relapse. So you have to keep continuing the elastic to get better. And we are done. Do you think the transverse looks better? I still feel the upper looks constricted compared to the lower. It is what it is. If you had expanded the bonded RP, this case would have been very nice. But the rotations are corrected. Look at the 2-3. 2-3 was completely out of the arch. It's very well aligned right now. Looks great. All the rotations are corrected. Doctor says I removed the braces today. She's going to see a specialist and for a gingival grafting. I hope her posterior will settle more. Congratulations. This was her first case. Isn't it great for the first case? I think she did an excellent job. Because she did well, we did learn from it. Finishing, you can still see the posterior bite is not so great. Why? On this view, if you see, I can see the cross bite is still there. Isn't it? See the cross bite is still there? That's what is creating the problem. And of course, gingival graft, but it looks great. Everything else that she's done a great job. Tooth number 2-2 still does not have a lot of labial root talk. We can sometimes during finishing, if you see this, you can change the bracket of that specific tooth only. Remove the existing LI bracket, put an LA bracket, and do a finishing wire. Which finishing wire will you use at that time? Can you use an 018 wire? No. You have to use 18 by 25 heat activated granite. A new one, not the one that you've already used before doing alignment. You have to use a new one. She looks great. How's the profile looking? I think her profile improved a lot. Lips are getting a lot more support than what it had before. The incisors, they don't look proclined on the side smile view. There's some amount of cant, probably because she had some asymmetry. Face looks well balanced. The lips are meeting very well. See this picture versus this picture. Can you see that she has bigger chin? How did that happen? Starts with G. Genioplasty. No. Growth. Okay. For an adult, if you see that, it would be genioplasty. So for a person, I wish my first case looked like this. It's really great to have a case looking like that. Okay. The transfers did improve, but it's insufficient still. What would you do to improve the transfers further? You use an expanded arch wire and you could not fix it. Can you do something to fix the transfers more? You can't expand the upper, then you have to constrict the lower. How do you constrict the lower? IPR. Go to IPR and chain, so constrict the lower. Or use a constricted arch wire as well. What is better, this versus this? Alignment is good. Anything else? Class 1 is good. Anything else? What about the photography? When you start a few cases, then you make some money, and then you buy a new camera. Okay? So that's the thing I'll tell you. The quality of pictures have to be good, because before pictures, I'm sure this was from a mobile. This is from a DSLR. Why do I see it? Because in this picture, I can see the posterior is very, very well. That's called the depth of field. A DSLR with macro lens takes all the pictures all the way back. But here, I can't see anything in the posterior. That's your mobile pictures. Okay. Even the skills of photography is improved, because when you want to take an occlusal picture like this, that is a real skillful job, because you have to make the patient open the mouth a lot, put your occlusal mirror, and the angle at which you shoot the picture should be 45 degrees to the mirror, so that none of the labial surfaces are visible. That's a good occlusal shot. Over here you see the labial surface is visible. That's not a good angle. That's like going all the way back to the 7. Ask the patient to hold the breath for a second and then take it, otherwise these mirrors will get fogged. You can't see anything on that. Start versus final. Everything looks good. What do you think about the E-plane? E-plane is a line connecting the nose to the chin. Lips were way behind the E-plane. That's called a concave profile. In this, the lower lip is now touching the E-plane. That's called a straight profile. So your treatment plan gave them from concave to straight. Overlays. This is what I was going to show you. Since she was a growing patient, an SN overlay shows you the growth of the face. You can see the red is after, blue is before. The entire face grew. But this is what is important. When I do the A-point overlay from start and final, the lower jaw had 5 millimeters of differential horizontal growth. How much do you expect a class 2 girl to give you in an estimated system? It's 2 millimeters. You expect 2, but you get 5. So it makes your case more easy. That's why you hardly see any class 2 correction that happened in the case. Okay? And this shows you upper incisor went forward and downwards, lower incisor went forward and upwards. Why did that happen? Because you're trying to connect the open bite. When you connect the open bite with elastics, you're going to extrude the incisors like you see in the red lines here. Okay, so that's about this case. Very nice. We saw one case of aligners with class 2, finished excellent. See another case with brackets in class 2. Okay, all these are correcting class 2, which is an AP problem without extraction, which means the amount of class 2 should be less than 4 millimeters. Okay, tomorrow when we come fresh again in the morning.